This presentation of asthma has been brought to you by students of California North State College of Pharmacy, class of 2013. The members consist. Asthma is a chronic respiratory condition in which a person's airways become narrow, making it difficult to breathe, and there is currently no cure to this disease. It's characterized by coughing, wheezing, and shortness of breath. As you can see, there are many triggers of asthma. One could be molds, others could be feathers, certain foods, dust, cigarette smoke, pollen, and animals.
So besides environmental factors, what other things may cause asthma? Things like respiratory infection, exercise, drugs, such as aspirin and beta-adrenergic antagonists, and genetics may also cause asthma. A genetic cause of asthma is linked to the low expression of the macrophage migration inhibitory factor, which is also known as MIF, which has been strongly linked with patients that have mild asthma. Macrophage migration inhibitory factor, MIF, is an immunologic regulator that is expressed in inflammatory and autoimmune disorders. Hallmark of asthma is inflammation. So before we go into detail about the pathways that lead to the inflammation of airways and the process that leads to asthma, I will first talk about the major key players. One of the primary players are mast cells. A mast cell is a resident cell that contains many granules rich in histamine and heparin. Although best known for their role in allergies and anaphylaxis, mast cells play an important protective role as well, being intimately involved in wound healing and defense against pathogens. Then we have eosinophils, which are white blood cells. They are one of the immune system components responsible for combating multicellular parasites. Along with mast cells, they also control mechanisms associated with allergies and asthma. And of course, we have our macrophage. Macrophage is a type of white blood cells that ingest and take in foreign material. Macrophage are key players in the immune response of foreign invaders, which ultimately initiate the inflammation process of asthma. And this is Nguyen, and I am going to talk about asthma at the cellular level. At the cellular level, inflammation is characterized by mucus blocking. The mucus blocking, the epithelial cell shedding, basement membrane thickening, inflammatory cell infiltration, and smooth muscle cell hypertrophy and hyperplasia. During the asthma attack, mast cells become activated and occurs when all antigen cross-links with immunoglobulin IgE. IgE complex trigger mast cell degranulation, leading to rapid release of inflammatory mediators, histamine, prostaglandins, glucokinase, and leukocytes. The mast cell degranulate rapidly release within 30 minutes. These mediators lead to smooth muscle contraction and vasocongestion and leakage, resulting in airflow obstruction. The early acute asthmatic response is where the immediate hypersensitivity reaction occurs. However, it subsides at about 30 to 60 minutes. When airflow obstruction occurs in 3 to 8 hours after the acute attack, this late asthmatic response is more severe and lasts longer. During the late phase, there is an increasing influx and activation of inflammatory cells such as mast cells, eosinophils, and lymphocytes. Here is the process of asthma pathogenesis at the cellular and molecular level, as I was just described all the processes of the acute phase and the late phase of the asthma. Here I have a picture of a real biopsy that was taken from a teenager during an asthmatic attack. As you can see, the inflammation and the remodeling in the asthmatic airway. I is representing mucus plugging. I is representing inflammation, and MP is mucus plugging. SF is subepithelial fibrosis. MH is myocyte hypertrophy and hyperplasia, and lastly is neovascularization in the autopsy of this teenager lungs. As you can see, the mucus blocking right in the middle of the cross-section area. That's basically show the late phase of asthmatic attack, that the mucus is blocking the alveoli and causing the bronchoconstriction at the late phase of asthmatic attack. Alright, let's look into the drug targets. There's two types of drug targets, short-term control and long-term control. Short-term control is achieved by beta-2 agonists. Long-term control is achieved by leukotriene modifiers. So how do beta-2 agonists work? They are bronchodilators. They relax the muscle lining the airways within 5 minutes. They increase airflow, making it easier to breathe. They relieve asthma symptoms for 3 to 6 hours. Let's look into the pathway of beta-2 agonists. Beta-2 agonists activate adenylate cyclase, which generates cyclic AMP, which then activates protein kinase A, which in turn inhibits phosphorylation of myosin, and that lowers the intracellular calcium concentrations, which causes relaxation. Here's a table of some of the drugs that are used for asthma. And we have the side effects listed. For ProAir, some of the side effects include rapid heartbeat, dizziness, nausea, and vomiting. For Advair, side effects include sore throat, runny nose, upper respiratory infection. Singler and Zyflo are leukotriene modifiers, and we're going to go into details about that.
Leukotriene modifiers are the long-term control. They are leukotriene antagonists and lipoxygenase inhibitors. Leukotriene modifiers interfere with the synthesis or blocking action of the leukocytes, have both bronchodilation and anti-inflammatory properties. Not recommended for acute asthma attacks. Should not be used as only therapy for persistent asthma. As you can see, singular and alkylate, there are LG receptor antagonists, and they both inhibit L2B4 at the L2 receptor, which prevents the airway edema and smooth muscle contraction, and hence secretion of the mucus. As you can see, Zyflo, which inhibits the 5-lipoxygenases, and which causes basal contraction. And this is a picture of the leukotriene synthesis pathway, and at which point the leukotriene modifier exerts their effect. As you can see, the alkylate and cingulate, they inhibit the L2 receptor, and then Zyflo, they inhibit the 5-lipoxygenase enzyme.
Next, we're going to discuss some current and future drug targets. Currently, IgE is one drug target. Allergic asthma triggers increased circulating IgE levels, and active IgE binding to its receptor causes airway inflammation. Xolair is a drug approved by the FDA to neutralize free IgE by blocking its binding site, preventing subsequent inflammatory reaction. A future drug target for asthma is the PPARs, peroxisome proliferator activated receptors. Activating these receptors decreases pro-inflammatory gene expression and activates anti-inflammatory pathways in the lung. Specifically, PPAR gamma receptor ligands inhibit the release of pro-inflammatory cytokines from activated macrophages and eosinophils in the lung. To summarize, asthma is a chronic respiratory condition characterized by inflammation and airway constriction. Allergic triggers play a role in the disease as well as genetic factors. Mast cells, eosinophils, and macrophages are key players in the pathway leading to asthma inflammation. Currently, beta-2 agonists are used as short-term controllers and leukotriene modifiers as long-term modifiers in asthma treatment. In the future, drug therapy will likely target factors that can modulate the disease, such as IgE, PPARs, and the TRPA1. We've included some of our references for further information on asthma. We hope that you've enjoyed our presentation.